So my name is Verna. I'm a psychologist and a social worker by trade, also a certified care manager, and have been doing behavioral health with health centers and in health centers for longer than I care to recount. So we're going to spend the next bit of time talking about collaborative care, which is one of my favorite things to talk about, next to suicide safer care. And I'm really sorry that I'm not able to do that in person tomorrow. But we're going to talk about collaborative care. And collaborative care is a model that is continuing to grow. And so what is collaborative care? So we all collaborate on care. That's what we do, right? In health centers, we do that better than anybody else. However, collaborative care is a very specific evidence-based model to identify and treat patients with depression and anxiety in healthcare settings. And so there's lots of terms now. We use integrated care. We use all these different terms for sort of bringing primary care, behavioral health, can't forget our folks in dental, right? Everybody together to be able to care for patients. And so oftentimes integrated care is sort of used very broadly, and collaborative care gets thrown in there. But collaborative care is actually a very, very specific model. It came out of a research project in the late 90s, early 2000s. That was 1,800 patients, over 400 primary care providers. It was originally seniors, and it was around depression. And it was really the first time that a mental health diagnosis had been identified and treated in a primary care setting. And you were very fortunate to have folks from the Haag Foundation in Texas who funded that work early on, shortly after, a couple years after the research trial ended. And so what's interesting is at that point it was called Impact or Project Impact, came out of the University of Washington. One thing that they found when they were going around and asking people to be in the research trial, they went to an organization and talked to the medical director, and they found out that there was an embedded behavioral health person. And they said, no, you know what, you've got a behavioral health person here, we're not going to put you in our study. And the medical director said, you know what, I actually think we could do better than we're doing now. And when they put in collaborative care, meaning that they put a system in place to really care for patients, patients actually got better than just having an embedded behavioral health person. And so this is really about putting a system in place to care for patients with depression and anxiety. So it was Impact or Project Impact, now called collaborative care. It has been supported now in over 100 randomized control trials. So if you're somebody who likes data, if you're somebody who likes to read articles, then there's 100 of them that you can actually read that support collaborative care as being effective. And there's also lots in there around underserved populations, adolescents, adults, geriatrics. So lots of research there around different types of populations. And now we know, particularly since Texas now supports collaborative care, that it's sustainable, that you can actually do it. So collaborative care was recognized by CMS in 2017, the Center for Medicaid and Medicare, right? And they gave very specific CPT codes for collaborative care in 2017. Since then, it's been adopted by every single commercial plan in the country. Some of them even have special incentives, like United has special incentives to do collaborative care. Even the small local plans reimburse for collaborative care at this point. Of course, Medicare Advantage, and then Medicaid in 25 states now. Texas actually is one of them. So these codes that we'll talk about are on the Medicaid fee schedule. So the short version of this is that you can do collaborative care and bill it across all of your payers, not just Medicaid, not just Medicare, right? All of your payers. Many of you don't have very many commercial patients, but certainly your Medicaid and your Medicare. So what does collaborative care look like? So collaborative care adds two key people to the primary care, women's health, pediatric team, right? The first is a collaborative care clinician, collaborative care manager. And this person, according to CMS, does not have to be licensed. And we'll talk a little bit more about that. But it has to be someone that can do all of the treatment choices in collaborative care. So this person works really closely with that provider and with the patient. And the beautiful thing about collaborative care is that it is very patient-centered. As a clinician, I love practicing in collaborative care. It gets me the ability to use all my evidence-based practices. I see people get better. I have flexibility. Like, it's fabulous. It's everything I wanted to do as a clinician. I work with that patient sometimes every day, every other day, right? Depending on what works for them. Because the thing about collaborative care, it doesn't pay by the session. So we're really used to behavioral health being delivered in, like, I go and see you, we chat for 45 minutes, you bill, right? Collaborative care is a monthly case rate based on the amount of minutes that we spend doing patient care activities. So what that means is I can be super flexible in how I care for that patient. I can talk to you for 5 minutes. I can see you in person for 30 minutes. I can have a video call with you for 15 minutes. It can change all the time. It's based on whatever the patient needs. So very, very patient-centered. So that care manager works very closely with the patient, keeps that provider in the loop. There is a registry. So the registry is to make sure nobody falls off the radar, right? Really helps us track our patients. But most importantly, this is about a population. This is not just about the some people that we think need some follow-up or support who have depression. This is your entire population of patients who have depression or anxiety. So if I came to your health center and I ran a report of everybody that was on a medication, everybody that had depression on the problem list, or everybody that had scored positive on a PHQ-9, I would reconcile that. That would be your collaborative care population. Everybody with depression. Not just the people we think need counseling. So we have the registry to do that. And also we have the registry to track whether or not people are getting better. Collaborative care is measurement-based. We use the PHQ-9 for depression and the GAD-7 for anxiety, and there's some other tools now that have come in, right? And how many of you know that there's outcomes for depression or anxiety? Shaking your head? No? Yeah, you know, right? So anybody with a score over 10 on the PHQ or the GAD becomes a collaborative care contender, right? And where do we want to get people? Below 10, and ideally below 5. So we want a 50% or 10-point reduction in 90 days. Some states like New York, it's 70. But we want that 50% or 10-point reduction in 90 days. That's our outcome measure. Sometimes we lose patients because we don't tell them. So measurement-based. So we use the registry to help us know who's getting better and who isn't. And the psychiatric consultant is the second person added to the team. So the interesting thing about the psychiatric consultant, I know this is old news for you. You could probably stand up here and do this. And so the psychiatric consultant, they don't see patients and they don't prescribe any medications. They meet with that care manager every single week and they talk about patients that aren't getting better, meaning I've been 3 weeks and my score is still the same, or it's just gotten better by 2 points. I've gotten worse by more than 2 points. I'm at risk. Maybe I have some suicidal thoughts. And I think collaborative care is actually a higher level of care for people at risk for suicide. Or the provider wants me to get talked about, I'm having side effects, right? And they make recommendations to that healthcare provider in the electronic health record. So that psychiatric consultant has to have access to the electronic health record. We worked with our fabulous friends over here and Susan. They contracted with an external psychiatrist. He had access to the electronic health record, and he did their consultation for them because he could see the labs, he could see the medications, right? He was lovely. We loved him. And so he is a lovely guy. And so that's the psychiatric consultant. So those two people get added to the team. They get added right to the primary care team. And that's what collaborative care. So without those two components and without that registry, you don't have collaborative care. You have to have those things. So pediatrics, people say to me, well, how old for collaborative care? Technically, the PHQ and the GAD are ages 12 and up. However, now a lot of folks are doing pediatrics ages 6 and up, and they're using the Vanderbilt for a 50% or 10-point reduction. Because what usually happens in usual care for kids with ADHD, one, many of them are not actually ADHD, which is a whole other talk, but also that then you have a lot of times a child might be on medications, they come back, how's everything going? Oh, much better. But what we really mean is the hyperactivity got better, but we don't actually, the attention didn't get better, it's just nobody's really paying attention, right? And so now we have somebody really watching and saying, well, actually, the hyperactivity got better, but we still have some struggles over here. So maybe we need to talk to the psychiatric consultant and make some recommendations. Or it's much better in school and the teacher isn't saying anything, but at home, we're still having some problems at the end of the day. So maybe we need to get some recommendations, right? And you're going to see more and more about the 6 to 11-year-old population, particularly 10 and up. So you're going to start to see some measures and some things. So if people are thinking about peds, then we can certainly talk about it. So here's the core principles of collaborative care. It is, again, incredibly patient-centered. No patient schedule should look the same. So I have a really easy job sometimes because I get to go visit places and they tell me they're doing collaborative care, and I walk in and I ask them, show me the schedule. Or tell me about how you schedule patients. And if they tell me they schedule patients every week or every other week, I say, good, my work is done. I hope there's good shopping around here because you're not doing collaborative care. Every patient looks different and different from week to week. And that's the way collaborative care should be, very, very patient-centered. Population-based, not just the people who we think need any counseling. Think about a diabetic population. Every diabetic needs something different. Some people need a diabetes educator and home visits and help with medications and training around how to take insulin, right? And other people, you need to see them every 3 months and they're cool, but you still need to watch their A1C, right? And so think about your entire population of patients. Very, very treat to target. So we're not waiting around. If we put Lorna on a medication, we're not going to say, you know what, Lorna, we'll see you in 6 weeks and see how that's going. That's too long. We've already burned up more than a third of our time. We're not waiting 6 weeks to see if Lorna's getting better. We are laser focused on those symptoms. Laser focused. If Lorna's not getting better, we're going to do something different. Change a med, up a med, or maybe change something different in treatment. Maybe I'm going to do some motivational interviewing. Maybe I'm going to whatever, right, to be able to do that. Evidence-based care. All of the tools that I have in my tool belt to treat patients with depression and anxiety, interpersonal therapy, cognitive behavioral therapy, motivational interviewing, all of those, I pull them out all the time in collaborative care. So collaborative care is in of itself evidence-based as an umbrella, but underneath it, we do all the same things we've always done because they work, right? We know they work. Accountable. I am accountable to make sure that people are getting better. And I see people get better in collaborative care. And this true story, when we first started doing collaborative care, or impact at the time, I had gotten funding from the original foundation in New York. And my CEO, who was a family practice doc, worked in, health centers for a long time, he kind of didn't get it. And so I said to his nurse, give me the patients that every time they walk in, he kind of rolls his eyes. And I took those patients and I put them in collaborative care. And then he came to me, he's like, what did you do with those patients? I said, remember that collaborative care thing I was telling you about, that impact project? All those patients have depression and anxiety. That's really what's driving a lot of this. He's like, well, could you do it with other patients? I'm like, yeah, this is kind of what I've been telling you, right? And that's how collaborative care started. He had to see it. And that's very, very accountable to get people better, the whole population. So it is short term, meaning that the average time in collaborative care is about 6 to 8 months. Not because it's brief treatment or brief therapy. I don't even like those words. I don't even know what that means. If you said to me, Verna, really glad you're in care, you're going to get brief treatment, I'd be like, what is that? And I'm a clinician, right? I don't even know what that means. What I want is to get better. So do that. Generally, it takes, whether I am in a community mental health center doing collaborative care or sitting in a cornfield in Texas, if I'm focused on your symptoms and using evidence-based interventions, it's going to take you 3 to 4 months to really start getting better. That's what it takes. So the average time in collaborative care is about 6 to 8 months. So this is my favorite part of collaborative care, because these are the treatment choices. So symptom monitoring. We are laser focused on the symptoms. Why do I love the PHQ-9 and the GAD-7? Who loves the PHQ-9? Am I the only one in the room who loves the PHQ-9? Oh, we need to talk. So why do I love the PHQ-9 and the GAD? Because it gives me a really solid foundation to talk about symptoms. Tell me about your sleeping. You're a 3. What works? What doesn't work? What's one thing we could do today to help you sleep better? We are laser focused on your symptoms, because the big problem is what you're experiencing every day. You're experiencing those symptoms every day, and I want to change your daily experience. So now we are laser focused. We have something to focus on, right? And so symptom monitoring, maybe I just say, listen, sounds like you're cooking along okay. Why don't we talk? We have a way to measure now. We measure your temperature or your blood pressure, your emotional pressure. Can I give you a call maybe twice a month? Just ask you a couple of questions, let your provider know how you're doing. Yep. Camilla says to me, yep, that's cool. She's in symptom monitoring. Medication adherence. It's really hard to take medications every day. How do I know this? Because I'm terrible at taking my medications every day, and I'm a reasonably functional human being, right? And when my provider asks me, so Verna, do you take your lisinopril and your metformin every day? I lie like a thief. And so for no reason other than I know what I need to do, I'm not doing it, and I don't think he's going to be particularly helpful if I told him anything different, right? I'm just being honest, although I'm really trying. And so now, though, medication adherence. I like the CDC medication adherence tool because it asks really great questions, tell me about the times when you don't take your medication. And then I could say, well, when I'm on the road, I have a really hard time when I'm on the road, right? And then we could problem solve. Or Verna, tell me about times that you take too much or too little of your medications on purpose. Well, I take a little extra on the weekends because I want to sleep better, right? Or whatever it happens to be. So real world questions. If there's some problem solving we can do, I'm in the medication adherence treatment choice. So the thing about the CDC survey that I like is you can measure it. I get better, right? And then behavioral activation. This is my absolute favorite because I see it work. And turns out this doesn't just work on patients, it works on family members and coworkers too. So behavioral activation is really goal setting. And this is hard to do, and I've been doing it for decades. I still have to pay attention. So goal setting, most of us set goals that are way too big. One of my favorite, for ourselves and our patients, one of my favorite things to do is to look at a medical chart for someone that's been in care for a couple of years, and I pull out all the goals. The behavioral health treatment plan, the primary care goals, the diabetes educator, the community health worker, and I look at them all and I line them all up. And I've seen as many as 17. And I look at how many are got done, generally not very many, if any, right? Because there's too many, they're too big. So one of the things we talk about as being an effective healthcare team is that we have a shared care plan. So, but goals for depression and anxiety in particular, tremendously helpful, but very, very small. What's the one thing you could do today to help you feel less sad? My rule of thumb is if it's before lunch, I'm very food focused. If it's before lunch, then it's today. If it's after lunch, it's today or tomorrow. Why do I make it so short term? Because then you don't give me a goal, well, I want to lose 50 pounds, get a better job, and get along better with my mother. None of those things. If they were that easy to happen, you would have done them, right? And so very, very small. I want you to get a quick success. Because one of the things, unfortunately, our patients don't get successes. We spend a lot of time telling them what they didn't do. You didn't keep the appointment. You didn't go to the cardiologist. You didn't lose weight. You didn't check your sugar. You didn't stop eating ring dings, right? And so I want to give them a quick success. Patients that get a goal and get that quick success are 50% more likely to engage in care and 50% more likely to have a good outcome. So, what does this look like in real life? I had a patient, very true story, talked to him, and I said, I see you were in to see your provider today. Talk to your provider about you've been feeling sad. And I see that you talked about walking. You're going to walk. How likely are you to walk? I asked him, how helpful do you think walking is going to be? I think it might be helpful. How likely are you to walk? Not likely at all. Because I wear slippers. My feet are swollen. I don't even wear shoes anymore. I wore slippers to the doctor's appointment. Okay. What's something you think you could do to feel less sad today? I do think it would be helpful for me to be outside. I never go outside anymore. What's one thing you might be able to do today towards your goal of going outside more? Well, I could go out on my porch. What would you need to do to be able to go out on your porch today? Well, my son put away all my chairs because it was cold and I don't sit in them, so they're all in the basement. So I wouldn't really be able to go out because I can't really stand for a long time. So what would you need to do towards your goal of getting a chair on your porch? Well, they're in the basement. My son would have to bring them up. What would you need to do, right? Well, I could call my son. When do you think you might be able to call your son today? Probably after dinner, before he puts the kids to bed, but after they've had dinner. What time would that be? Probably like 7. So you could call your son tonight at 7 and ask him if he could come by and bring the chair up on the porch. I could do that. You know what I'd love to do? I'd love to give you a call tomorrow and see how that went. So what did we do? We celebrated that success. The son came over in the morning before work, brought the chair up, and guess what happened? Had a cup of coffee with him and invited him over for dinner that weekend. So now, guess what? Now we've got some rolling effects here, right? So guess what happened? We sat outside. Guess what happened when we sat outside? We saw the neighbor. Go figure. Right? And so gradually, those short-term goals, right? So then what do you want? What else do you think you could do to feel less sad? Well, now his affect has kind of changed. He's had some successes, right? And so guess what happens to those PHQ scores? I've had people that their goal was to stand outside and then get a tomato plant. They went to the neighbor. They were going to look at the garden. Then they got a tomato plant from the neighbor. Like, you wouldn't pick a bra. I'm going to find a bra. I haven't worn a bra in years. Like, whatever patients pick, right? But that is behavioral activation. It, to me, is like magic. It's magic. But you have to get good at it. You have to be like, can I make this any smaller, right? So behavioral activation. And then talk treatment. So talk treatment is a treatment choice in collaborative care. Only about 15 to 20% at any given time should be in talk treatment. And talk treatment is therapy. It can happen in 30-minute sessions every week, right? It doesn't have to happen every week. It could be like, Lorna, sounds like you have a lot going on. Maybe we could schedule a longer time next week so we could talk. Lorna's in talk treatment for maybe just a week, or maybe ongoing. To be honest, most of the time I don't even bring that up, because when I meet somebody, I say, gosh, it's really glad we had a chance to talk, right? Because most collaborative care is done over the phone. It was done over the phone before it was fashionable with COVID. It's been done, the first collaborative care ever impact was all telephonic, because it just works best around that behavioral activation. So really glad we had a chance to meet. I see the provider put you on some medication. I ask you about your medication. If you say yes, you want me to follow up, you need help, you're in medication adherence. What's something you could do to be less sad? You say yes, you're in behavioral activation. You say no, man, Verna, sometimes my most engaging, endearing self, people are like, nah. Then I talk to them about symptom monitoring. Most of the time, I'm already going to talk to people 2 or 3 times that week. I don't even need to ask them about talk treatment. So that's how collaborative care sort of plays out. And these treatment choices, people can be in one of them or all of them, and it can change from week to week. That is the spirit of collaborative care. It is not a constant. And patients will choose. So it can flex all the time. So if there's any constant scheduling, then it's not really patient-centered. And no one should look alike. So care managers. So who can do care management? So the interesting thing I said, doesn't have to be licensed, right? However, some states require licensure. Texas does not. So they have to be able to do all of the treatment choices. So there are some treatment choices in talk treatment that are in scope for people who are not licensed. Problem-solving treatment, PC, some behavioral activation. So it is possible. They can be master's prepared. What I tell a lot of organizations, get a good master's level student and let them work themselves into a job. You can bill for them, work themselves into a job. Here's the key. It has to be a dedicated person. Here's what doesn't work. We have Camilla, and she is a social worker in a primary care practice, right, in a health center. And someone in administration hears me talk about collaborative care and says, oh my gosh, I love this collaborative care thing. It sounds amazing. We're going to do it. Camilla, you know what? We're going to do collaborative care now. And so for your patients with depression and anxiety, you're going to do this collaborative care thing. That fails every single time for the most part. Because she's pretty busy already, right? Why do collaborative care? It's a little more work. It's more evidence-based. You have to have a registry. You have to do this. The schedule is always changing. So how could she possibly work around other appointments, right? So you are better off to come up with a good launch plan for collaborative care to be self-sustaining, which could happen in month 2, than have somebody be split. Split does not work. It will occasionally work if somebody really gets collaborative care and they do a little bit of something else. It almost never works in the reverse. So also the remote really expands your staffing options. So if you can't hire a behavioral health person, or you need to have someone on site and you want to do collaborative care, hire a remote person. They can be sitting out in the middle of nowhere. They can be a military spouse who's licensed in Texas but is sitting in some other state, right? It expands your pool of people who can cover. They could cover multiple locations. You can share them across. And here's the kicker. These collaborative care are primary care codes. It is not a behavioral health initiative. It is a primary care initiative. The codes can only be billed by primary care providers. So what does that mean? That means your behavioral health people don't have to be credentialed in the plans. They're not the billing providers. So that makes life much easier. For the plans, they go through primary care. They don't get carved out into any behavioral health benefits. So makes life much easier. You could hire me today. You could start me working along with Sue's team there, right? And I could be billing collaborative care in the beginning of November. So here's some things that we've learned are not helpful. So one of the things is we don't want to present the list of options. I never even use the word collaborative care with patients. They don't really need to know, right? They want to get better, and I want to get them better. And I never say, here's your choices. I had a care manager the other day. She was cute as a button, but she was not engaging people. And she said, I have a list of all the treatment choices that you gave me, and I hold it up and I show it to the patients, and then we go through them one by one. And I said, well, now I know why you have 9 people on your caseload, right? And so we don't need to go through the treatment choices like that. And then also let people know that they can transition. Hey, we don't have to talk every week. That's cool. You have the flexibility to change it when it's helpful, when it's not. And so when you give people that choice, you'll be surprised they'll call you and say most of the time they just blow off 4 appointments until we're going to lose their slot, right? Now they can tell you, listen, I don't think I need to talk this month. My sister's in town. I'm going to be really busy. Let's revisit this in June. But yeah, we can talk so you know how well I'm doing, right? So it's very, very patient-centered that way. And also letting them know. So when I go to the primary care provider, they have no qualms telling me what I weigh and what I should weigh. And generally, there's a larger gap there than I would like. And so oftentimes, though, we don't tell people, listen, you scored a 26 here. We would really like you to be around a 5. Because a lot of times people start to feel better, and then what happens? We stop taking medication, we drop out of care, we don't keep the follow-up appointment, right? But we don't actually know we were only halfway there. If I knew that, I would make different decisions, and then I could say to you, listen, I'm feeling a lot better. I don't think we need to talk every week. And then you could say, well, we could just check in so we can make sure you're still getting better. And you could take me to symptom monitoring. So letting people know how they're doing. So some misconceptions, right? That it's not therapy. So here's what people will say, well, collaborative care is not therapy. I say, well, here's what therapy is. Therapy is somebody who is treating a mental health diagnosis with evidence-based interventions. The only reason we do it in 45-minute sessions is because that's how we bill. But actually, it's kind of not what it is, right? Those are the psychotherapy codes, but it's not actually what it is. And so I say, you know what? We've learned a lot in behavioral health, like we have in primary care. We don't care for diabetics how we did even 5 years ago or 3 years ago. Think about HIV, right? How different we care for HIV now, or some of the other chronic illnesses. So we've learned a lot about what gets people better who are feeling sad. And one of the things we know is behavioral health treatment is better in doses, like medication, right? You don't generally get 1 pill to take once a week now, right? You get doses. I joke with people, you're going to get a dose of me all a couple of days a week, right? How good is that? And so, but the idea is like it's better in doses. And so we're going to give you a dose of treatment. So people say, I want therapy. Good, we're going to give you therapy. We're just going to give it to you in doses. And that's what really helps people get better. And it's a good analogy for people, too, to kind of understand what it looks like. Here's the really important thing about collaborative care. So my organization just cared for their 70,000th person. And we looked at our data, and here's what we saw definitively. It was not the amount of time we spent with someone. I can see you, Rebecca. I can see Rebecca, talk to Rebecca in collaborative care once a week for an hour, for over 4 hours that month. Or I can talk to Rebecca 10 times on the phone for 10 minutes apiece. That 10 times on the phone, Rebecca is way more likely to engage in care and have a better outcome. It is not the amount of time, it is the number of contacts. We see this time and time and time again. Think about it in your own life. You're setting a goal for yourself. You've got a cheerleader that checks in with you every couple of days. How's that going, right? Way more helpful. Also, something we call front loading. Twice as likely to engage in care if I have a couple of contacts with you 2 or 3 times the first week, 2 or 3 times the second week. We are solid then. We've had some successes, we got a little rapport, we figured some things out that work, right? You are way more likely to get better. That front loading is absolutely critical. So who's appropriate for collaborative care? So when you think about depression or anxiety, those are big umbrellas. My New York hand's here, although I live in South Carolina now, I'm a transplant. But so depression and anxiety are big umbrellas. Lots of diagnoses fall under depression or anxiety. All of them are appropriate for collaborative care. One of the things that people will often ask me, usually the behavioral health people, I have a lot of patients that have long histories of trauma. Unfortunately, we care for people who have long histories of trauma. And that sucks, and I wish we didn't, but that's who we care for. And so here's what I have seen play out for those patients. Most patients, in fact, like 50% of them, when you make a behavioral health referral, particularly trauma, they don't go. They don't get there, they don't stay, right? However, short-term, high-touch, focused on symptoms, not experiences. Symptoms. Big difference. We can change your daily experience. So then what happens? I have some successes. How empowering is that? My daily experience has changed. How cool is that? I can see that I have some control, right? I've had a treatment success. So then what happens? If I decide to do something else, I'm way more likely to go and stay. And if not, I've had a treatment success and I'm way more likely to go in the future. So people with a history of trauma do fabulous. People with alcohol or substance abuse. I've had so many people say to me, it's the first time somebody talked to me about how he was feeling and not my drinking. They do really well in collaborative care. And then sometimes go on to do other treatment, but still have had a treatment success. So all of those people can actually go into collaborative care. It is super important to educate your PCPs. This will not be successful if you don't educate your primary care providers. It is a primary care initiative. I'm a behavioral health leader. I love behavioral health leaders. The minute I go and do a collaborative care implementation and the only person at the table is the behavioral health leader who put together a very nice team to meet with me, I know that I'm practically going to be doomed. It has to be the primary care leadership. They have to own it, they have to understand it, and they have to be at the table, and they have to be part of driving it. If that doesn't happen, it is going to be incredibly difficult to do this work. They also have to be on the same page for prescribing. That primary care providers are the prescribers. They have to be comfortable doing first and second line meds. They have to understand the entire population. I've had so many primary care providers tell me, I love collaborative care. How many patients do you have in collaborative care? 4, they love it. Then you don't understand collaborative care. It's your whole population of patients. I've had practices where they've had 40, 50 patients in collaborative care, and I've said, run me a report of all the patients you have on medication for depression that have never touched behavioral health. This practice in Arizona, 8 primary care providers. They had 1,000 patients that had never touched behavioral health that were on medications for depression. Nobody knew how well they were doing. Nobody knew whether the medication was working. And we outreached, and the ones we reached, many of them scored way over 10. So that's your collaborative care population. It's the entire population of patients. And you really have to embrace. So if you're going to do collaborative care, warm handoffs from providers alone do not make collaborative care. You have to have some population health approaches. It can't just be warm. And not every patient needs a warm handoff. Not every patient needs that level. Also, they have to be able to understand the language. I work with Lorna. She's part of my team. She helps me care for my patients who are sad. I'd really like for her to give you a call later. And then I tell them, stop talking. That's the warm handoff that people need. So that warm handoff, case finding, run the reports. Anybody that calls into the nursing line for a refill of medications, how well are they doing? Ask them the PHQ or the GAD. Meds might not be working, might not be the right meds. Or if they're in remission, then it should be marked in remission in the chart and updated, right? So that you're really figuring all of this out. So we can talk about what reports you could run to be able to know this. So outcome measures. We want to make sure that people are below 10 or below 5. That's your long-term goal. And share that. The primary care provider should know it. You have a UDS measure for depression. Does anybody know what the UDS measure for depression is? It's on page 106 of the UDS manual.
I don't know the page number.
Okay, that's okay.
The measure, right.
Yeah, so what is the measure?
There's actually 2. There's one, the one we've had for years.
The screening.
Percent of patients that are screened and receive a follow-up.
Yep.
The newer one that's just been in effect is remission within 12 months.
Within 12 months, right? So that you've had a PHQ drop in 12 months. So you should be a little bit more in terms of that 50% or 10 points in 90 days, but that will help you meet the UDS measure. So a lot of providers don't know the outcome measures, don't know that there's a UDS measure. So everybody needs to know, right, what the outcome measures are. If I go to Susan's practice and you're doing collaborative care and I ask all your primary care providers, are they going to know we're looking for a 50% or 10-point reduction in 90 days on the PHQ or GAD score?
Ask Dr. Rodriguez.
Oh, throwing Dr. Rodriguez under the bus. So Dr. Rodriguez should know this now, right? That he knows all of his patients are going to be 50% or 10 points in 90 days. And you're going to be tracking it, right? That's an important piece. That's a super important piece. I think you and I talked on the phone one time, maybe. And so, yes, so that's super important because if the primary care providers don't know that, then they're not going to schedule follow-ups the same. They're psychiatric consultations, right? So that's a really important piece to be able to know. So here's the thing about the billing. So CMS was not kind to FQHCs in that they put G codes in for collaborative care as opposed to the CPT codes. But either way, you can bill for collaborative care, Medicaid, and Medicare, and your commercials. There are 4 CPT codes for your commercial plans and the G codes for an initial month and then follow-up months. So now here's the things that are included in the monthly case rate. So it's any activities that are patient related. So the thing about these codes is, again, they're a monthly case rate. You can fit them into your sliding fee scales. Most practices, FQHCs, are putting like a monthly case rate for collaborative care in their sliding fee scale as a consideration. There has to be a referral from the primary care provider to start the clock. So if I'm a care manager and I meet a patient in the waiting room, right? That time doesn't count until you make the referral in the chart. So that referral by the PCP starts the clock. That's really important to remember. That consent has to be documented, but not with signing a written form. It just has to be documented by the PCP or the care manager. Generally, the referral to collaborative care supports the discussion and the consent, and then most places have the care manager have a follow-up conversation about consent for collaborative care. So here's the things that are included. Psychiatric consultation. So the time in psychiatric consultation. The psychiatric consultation is dedicated. It happens every week. It's not like we have an open door policy. It's dedicated time every week for case review. It's only counted once in that if I talk to my psychiatric consultant and we spend 10 minutes talking about Lorna, it only counts as 10 minutes. It doesn't count as 10 minutes for Lorna and 10 minutes for the psychiatric consultant. It only counts as 10 minutes. So generally, the care manager just documents it. Any time that I talk to the primary care provider, it counts as time for me, the care manager. The primary care provider can bill that separately with an E&M code. Not that it matters your PPS rate, but that can count or be done separately. But the time with the care manager, right? Anytime I update my registry. Most EMRs don't meet the requirement for a registry. There are some options. Epic does, MedEnt does now, some of the others. I have some options if people are interested. We can talk about it, but updating my registry, not updating the electronic health record. That's admin, that doesn't count towards time. Anytime I'm talking to the patient, in person, on the phone, video, doesn't matter. Any of that patient care time. Anytime with collaterals, parents, caregivers, spouses, right? Anytime maybe talking to them about the PHQ or in symptoms, right? Also, no concrete services. Housing, food stamps, transportation, disability. Nobody is going to dispute that those things impact depression or anxiety. Not disputing, just telling you they do not count for the minutes. So if you have a care manager doing those things, they cannot count towards the minutes. Some benchmarks, 90% of my time as a care manager should be attached to a billable episode for a patient, should be attached to billable minutes for a patient. I should have at least 90 patients on my caseload. That's the average caseload for FQHC collaborative care. Why? Because some patients are twice a month, some patients are more, right? I can have that larger caseload. And 90% of my patients should be billable for that month. So I don't carry them from month to month. If they're not engaging, I move them off my registry. So 90%. Burn is 90s. Questions? Comments? Was a lot of information. Good. Fire away, my dear.
Well, I'm brand new to everything.
Oh.
I got hired 3 weeks ago.
Congratulations.
Thank you. I'm traditional LPC.
Mm-hmm.
This is extremely different for me. So, in starting with my caseload, I have 38, 40 something.
So you're about halfway there.
About 40 something people to contact. And I started doing that this past Monday. So I'm calling.
For collaborative care or for care?
I don't know.
So that's
Quite
something that
honestly.
you need to figure out with your
Yes.
leadership.
Okay.
Very, very different. You're either going to do this or you're going to do this.
Right. So I started off with establishing contact, just kind of checking in, seeing, where the client's at, patient's at, and putting them on my schedule because of, how I am a traditional therapist, right?
Yeah.
For 60 minutes.
Oh.
So that's
You
I
shouldn't do
I
that
have a
even
lot
as
of
a
questions.
traditional therapist, but that's
Right,
another workshop.
right.
Okay.
So I'm just wondering how this will work in conjunction with like what I've done as a traditional therapist, and with the primary care model, integrating both, the billing, all of it. I have
So
questions
what
about all
I
of it.
would say is, and I don't know if your leadership is here
Mhm.
today, but I would be glad to hop on a call or sit with you and the leadership to pick, because generally you're trying to solve a problem, right? So we need to get behavioral health to our primary care population, and that's a broad spectrum of people. So either we're going to say we have a lot of depression and anxiety folks, we're going to do collaborative care so that we can serve a broad number of a big part of the population, or we're going to do integrated transdisciplinary behavioral health. We have this talented LPC now. She's going to see patients. She's going to be very symptom focused in her care,
Right.
no matter what diagnosis,
I can
very
do that.
symptom focused and caring for people. And you're going to have a caseload of 50 to 60 people at any given time. And we're going to think about diagnoses and outcomes so that people are kind of moving through, and that's what you're going to do. But you have to pick a lane, not you, but
Yes,
the
I do
center,
need to pick a
right,
lane.
has to, right, but they have to pick a lane, and that's a discussion, that I'm glad to have and help support. But it
Oh,
would be
absolutely.
very hard for you to do this without the organizational support behind you
Mhm.
to actually set up collaborative care.
Right.
Yeah.
Okay. Well, that's a little bit of my lots of questions.
Yeah, and then if your organization decides to do collaborative care, I will totally work with you. We will train you up. We'll train their primary care providers. We'll do what it takes to get rolling.
Okay.
Yeah.
Sounds good.
Absolutely.
Anybody?
So what happens? The person goes through the 6 or 8 months of collaborative care, they get better. Is there a maybe 3 months down the road something else happens? Does the clock start off again with the primary care doctor starting another session of collaborative care?
It could. So most places will say like 12 months total in collaborative care. Like a lot of payers won't pay for more than that or need prior approval. People can come back to collaborative care, right? Generally, what you're trying to do as part of a relapse prevention strategy is that I can identify things. I have things that work, right? And I can then use them so that my score doesn't go up. But I could come back into collaborative care. So, like what I do when I first meet someone is, let's just say I'm doing the PHQ. I take all the things that are a 0 or a 1 and I put them on the left side of like things that work. And I say, sometimes people that are feeling sad have difficulty sleeping, but you talked about sleeping fine. Has that always been the case? Well, actually, I started taking melatonin a couple of months ago and now I sleep fine. So one of the things that works is melatonin. So I'm going to put that over here on the things that work list. And then if I score a 2 or a 3, those are things that I'm identifying to target for a care plan. So these are the things that are the most problematic that you're experiencing every day so that we can start to focus over there. And so generally then, once we identify things that work, we move them over here as the scores go down. So that right from day one, I'm starting a care plan and a things that work or relapse prevention plan.
I'm the executive director of care management at JPS. So, as a safety net hospital here in Fort Worth, we have a lot of challenges. And we have a wonderful behavioral health division. And so they're looking into collaborative care. And so we're going into that direction. But we have access issues. And so I think a lot of our providers really want to do collaborative care, but we have a lot of things that we have to take care of. And so we have a lot of different programs that we manage, but we have tasks that they want us to take care of. And so it's hard to say, okay, I can get my care managers to do this, and that. And so it's trying to prioritize. That seems to be the problem. So if we already manage, 8 different programs already, and then we have the inpatient team, and we have throughput, you have length of stay, you have all of these things that are going on. So we have to focus on what is the priority.
Yeah, I would. Yeah, without question, right?
And does it take the social worker to do this DME paperwork? this.
Yeah,
this.
so I mean, and none of that is going to count towards the minutes, right? So what a lot of places do, particularly if they have other care management or chronic care management or some of the other,
That's us.
yeah.
Still.
So then what they will do, because people aren't really going to get better, right? Unless you've addressed some of the depression and anxiety. So the collaborative care will kind of take the front seat. That dedicated care manager will actually really hone in on the depression or anxiety for a period of time. The other person still works with them, right? Still does a DME order, still does a whatever. But that the collaborative care manager is like front and center for that period of time, and then it gets transitioned back. So it's like kind of bringing in the specialist, so, and they really hone in on those particular symptoms and then transition back. So you still have the continuity of that
Okay.
care manager, but you have someone else coming in. And as long as you're not an FQHC, you can actually build both of those things at the same time.
Okay.
So it's helpful.
And for our population, I mean, and you didn't touch on this, but like the social determinants of health really is like our priority,
Huge.
right?
Yeah.
Like we can't really focus on that until we address those priorities.
No question. And so I kind of think about it. So this comes from my health home days, right? I did almost like a quadrant. So you had very high chronic illness, low behavioral health. I had the nurse do what you needed. You had high SDOH, but you had low this. Then I had a care manager, not licensed person, do the SDOH stuff. You had high depression, anxiety, behavioral health. I had the social worker. You did collaborative care. So I put people in like 4 quadrants and then the buckets, and whoever they fell, that person took the lead. And then when they transitioned, so they had the continuity. It was just a matter of who was stepping front and center at any given time. Yeah, and so you could build in collaborative care very easily to this, and I'd be glad to spend some time and hop on a phone and help you talk it through and the codes and staffing and what that would look like for you. Yeah, totally. So my email is up there. Be glad to feel free to jot it down, shoot me an email. That's like totally not a problem to hop on a call. I don't care. I just want to see you do collaborative care. So if you did collaborative care, you would make my day. Yeah. Amazing. We've actually done some studies looking at anxiety and depression outcomes for that population. And so very much, I would say you're increasing the amount of times that you're screening. It actually works really well. And most women, particularly with anxiety, don't need medications. They just need some, skills that they can use to be able to help manage, and they do very well. The only problem that you sometimes run into with that population is that if someone does two things. One is if someone does need meds, the OB providers are generally not the people who are super excited about starting someone on depression or anxiety meds. So then sometimes you have to, like if they're not your primary care patient, also it gets a little muddy for collaborative care. Where I think collaborative care is super helpful is a lot of women come into care on meds. And the OB providers love the psychiatric consultations that say, hey, keep this person on meds. And we do some education around the meds and pregnancy and breastfeeding. And so that actually is super helpful, because then they're less likely to say, don't take the meds or decrease the doses, which you still actually see. So that is incredibly helpful. Yeah, but it works fabulous.
What's the
Yeah.
recommendation for those screenings through pregnancy and after, like?
So now anxiety screening is part of what's required as well. So generally you want to do 2 or 3 times during pregnancy. And now you're going to see anxiety be more prevalent than depression. Used to be the other way around. And then you want to do, right away following birth, and then first appointment, and then monthly probably thereafter. I now do, especially given some of the new data, the maternal suicide rates are on the rise, and most of those suicides happen in the first 42 days after birth. And so I actually like to really make sure we're asking very specifically. And actually some of the recommendations, the PHQ-9, people who answer yes on the PHQ-9 are more likely to die by suicide. So it's helpful. It's better than asking nothing, but actually research shows that it's not a great screening question for suicide, and you should actually be asking some other questions. So for that population, I like to ask very specifically about suicide, just given.
What about the Edinburgh?
So OB providers, I'm too old to argue with people. They are very wedded to the Edinburgh. You could argue the PHQ, the Edinburgh, they have pros, cons, whatever. The thing about the Edinburgh is it doesn't as specifically ask about suicide, and you can't score it over time. But, most of the time they use the Edinburgh.
I can piggyback on that. So the ACOG guidelines say that the depression and anxiety must be done once every trimester. That's the ACOG guidelines. And the PHQ-9 or PHQ-2, then to reflex to 9, there's a combination that you can do in the GAD-7 to look for anxiety. And then postpartum, you can actually do either or, PHQ-9 or Edinburgh. And as a plug to my pediatric colleagues, I'm a pediatrician, we also screen for postpartum depression on the pediatric side.
Yeah.
So we do that at generally at 2 weeks postpartum, and then at 2, 4, and 6 months. And of course, anytime in between if we see that there's a need to do it, based on symptoms. And although the mom is not our patient, we have a duty because the mother, that's the child who's being impacted by the mother who might be depressed. So there's quite a bit of screening for postpartum depression, or let's call it perinatal depression.
Yeah.
Because it can start from pregnancy through the first year of the baby's life. So you're talking many months, right? Almost 2 years worth of amount of time that perinatal depression can be diagnosed.
Yeah.
So the PHQ-9 is the one recommended by ACOG?
Either.
Either one,
Yeah.
yeah. For us in pediatrics, we only do the Edinburgh, but for the ACOG, either one you can do.
Yeah, where you run into the problem is for collaborative care, it's measurement-based care, so it's the scores over time. And so, but, it's not worth the...
In Edinburgh, you can score, but the scores are not equal to the PHQ-9. That's a different scoring system.
Yeah.
And furthermore, the metrics that we use for quality of care, especially around UDS, the ones that we use as federally qualified health centers, is specifically for PHQ-9.
Yeah. And most of the plans too, they track the PHQ-9. Yeah. So, that's the only, there's pros and cons, but yeah.
Harm, and it would actually be maybe beneficial to do the PHQ-9 prenatally and then stick with the Edinburgh postpartum.
I think if you should pick a lane and then do it over time. That would be my suggestion. Yeah.
There's so much variability in what providers do, right? I mean,
Yeah.
if the ACOG, all of those kind of, American Academy of Pediatrics, ACOG, they put out the best practice guidelines, but they're just guidelines, right? At the end of the day, they make recommendations and the provider can decide what they want to choose. And there's variability, of course, depending on who you see and who you're accountable to, right? And for your quality and things
Right.
of that
But
nature.
Organizationally, you should pick a lane, right? Because then you're looking at outcomes, you're looking across providers, across population. And so you should pick one or the other, so that you can have, it's not apples and oranges, right? It's apples to apples, and you can have some outcome measures. Yeah.